Hi everyone, my name is Nishchal Kumar and it is January 22nd, 2020, and I'm here to do my Unit 4 case connections presentation. And so the first case I did talked about uh, a newborn girl appeared at birth and she had some lethargy, hypothermia, and apnea. And so some labs were analyzed and were ordered and analyzed. And the first question was to ask which diagnostic tools would be the best in order to differentiate between a urea cycle disorder and a beta oxidation disorder. And the options were blood glucose, urinary acids, serum fatty acids, and plasma glutamine. And so what I said was plasma glutamine would be the best diagnostic to distinguish between a urea cycle disorder and a beta oxidation disorder. And I said this because glutamine levels appear normal in beta oxidation disorders while they are elevated in urea cycle disorders. And this occurs because glutamine is a non-essential amino acid that helps in the transport and detoxification of ammonia. And so urea cycle disorders are metabolic disorders that cause a deficient, or actually that are caused by a deficiency of one of the enzymes in the urea cycle that is responsible for removing ammonia from the bloodstream. So because of a urea cycle disorder, there's going to be elevated levels of ammonia. And with elevated levels of ammonia, there's going to be elevated levels of glutamine. So as we can see, there is the difference in glutamine levels between the elevated levels in the urea cycle disorder and the normal levels in the beta oxidation disorders make glutamine a great indicator of which disorder is present. And that's something the other three diagnostic tools do not show and cannot present. So the next question asked, after a full blood workup was ordered for the female, the ammonia level was elevated. Her urine orotic acid, I'm probably saying that wrong, but orotic acid level was elevated, and her plasma citrulline level was normal. And so it asked, so in this patient where the orotic acid levels are elevated, what's an enzyme that is most likely deficient and an enzyme that is least likely not impaired. So the enzyme that I talked about that was most likely deficient was the enzyme ornithine transcarbamylase, or OTC. And because of this deficiency, carbamyl phosphate builds up in the mitochondria and then leaks into the cytoplasm. And then it becomes part of pyrimidine synthesis, which ends up resulting in heightened levels of orotic acid in the urine. And this deficiency is characterized by lethargy, hypothermia, and apnea in girls that have it. And this patient is presenting with those exact same symptoms. So I'm thinking that that is the enzyme that is deficient. The symptoms match the patient's symptoms. So, and then the enzyme least likely to be impaired, I said, was carbamyl phosphatase synthetase 1, or CPS1. I know that's a mouthful, but so this deficiency is actually characterized by very low levels of citrulline and low to normal levels of orotic acid in the urine. Well, this patient actually has the opposite of that. She has normal levels of citrulline and extremely high levels of orotic acid. So, therefore, I'm thinking that CPS1 is not deficient and is likely not the enzyme that is impaired. And so that's it for case 1. And then, so the next case I did was case 2. And case 2 was about phenylketonuria and a four-day-old infant, which they labeled as patient A, um, were had elevated levels of phenylalanine, and so a diagnosis of phenylketonuria was made, and then some uh, you know tests were taken. But the first question that was asked was, as a consequence of this presentation, which amino acid may become essential? So what I said was, phenylketonuria is an inborn error of metabolism that stems from the absence of the enzyme phenylalanine hydroxylase, or PAH. And PAH is responsible in catalyzing the hydroxylation of the aromatic side chain of phenylalanine to generate the amino acid tyrosine. So as a result of this deficiency, tyrosine actually becomes a conditionally essential amino acid for patients that have phenylketonuria. So next, it was said that phenylalanine dietary restriction therapy was used to lower phenylalanine levels, and that seemed to have worked. And so the next question was, what are some causes of phenylketonuria? And then so I said, phenylketonuria, or PKU, is mainly caused by genetics. It's actually passed down by autosomal recessive inheritance, in which the parents of the affected person acts as a carrier of the defective genes. And as a result of this deficiency, when both parents transfer the defective gene, their offspring will end up expressing it. And then so next we are introduced to another infant, which they call patient B, and it's suspected that they're also afflicted with PKU, or phenylketonuria, and so these BH4 loading tests were performed on both patients, and the results were shown in this table. And we were asked to, kind of summarize the results of the test for the first patient, patient A, and the results of the second test for patient B. And these BH4 loading tests, which were the tablets of the synthetic cofactor, were dissolved in water, in dim light, and given to the patients at least half hour before a meal. And then their blood was drawn, and then their phenylalanine levels were looked at 4 hours after the loading test was given, and then 8 hours after the loading test was given. And then so what I kind of surmised from looking at the graph, which wasn't really too complicated, it was just the time after the administration of the BH4 loading test, compared to the phenylalanine levels. And so I, did some research about BH4 before I tried to figure everything out, and I found that BH4 is a coenzyme responsible for converting phenylalanine to tyrosine using PAH, which was the enzyme phenylalanine hydroxylase, which is not in patients with PKU. So BH4 is kind of like a substitute. And so when given the BH4 loading tablets, patient A's phenylalanine levels actually increased as time passed from 0 to 4 hours to 8 hours. And so we can infer that it is not possible for her to metabolize phenylalanine and convert it to tyrosine using the BH4 loading tablets. So I figured that the PHE dietary restriction therapy, which she was using before, should continue to be used with this patient, as it seems to be effective in bringing down her phenylalanine levels, which were elevated in the beginning. And then, oppositely, patient B's phenylalanine levels decreased significantly as time passed when given the BH4 loading tests. So this patient can metabolize phenylalanine to make tyrosine, and I suspect that the PKU or the phenylketonuria diagnosis is actually incorrect. So that's kind of what I surmised from the passage and the table and the graph. So thanks for listening, and have a great day. Bye bye.